That's fine. I will just work on being a little bit briefer than I had originally intended, but I can deal with it. So.
Okay. All right. Well, I think we'll go ahead and get started then. Welcome everybody to the Falls Prevention Community of Practice. My name's Stacy Klinker. I'm filling in for Lana Comstock today. She's out working with one of our hospitals. And before we go ahead and get started, let's take care of a couple housekeeping items. I'd love to find out who's in the room today. So if you could, in the chat box, type in your name, facility, and role, we'll get a better understanding of who's with us today. I'd also like to take a moment to remind you to mute your phone line so that way we can eliminate any background noise during the presentation. Also a reminder that if you have dialed in, please do not place the call on hold, as we will hear your lovely hold music played into the presentation. I'd like to really emphasize that, you know, we encourage discussion and questions. So if at any time during the presentation today you do have questions or comments, please feel free to type those in the chat box, and we will have staff moderating that throughout the event. Great, it's good to have you all with us today. Okay, and with that, I think we'll go ahead and start our presentation. Today we're going to be hearing from Dawn Venema, and she is the Assistant Professor at the Division of Physical Therapy Education at the University of Nebraska Medical Center. She has both clinical and research experience in fall risk reduction for older adults. Dr. Venema is a co-investigator on Capture Falls, a study funded by the Agency for Healthcare Research and Quality and the Nebraska Department of Health and Human Services. The purpose of Capture Falls is to implement a multi-team system as an organizational structure accountable for the process and outcomes of inpatient fall risk reduction in over 30 Nebraska hospitals. Dr. Venema has received several awards for teaching and research, including the 2017 Outstanding Teacher Award from the UNMC Faculty Senate and the 2017 Excellence in Teaching Award from the UNMC College of Allied Health Professions. With that, I'm going to go ahead and turn it over to Dawn.
Okay, thank you, Stacy. And I just want to assure everybody that Stacy and I did do a test run last week. So I'm quite sure where the technical difficulties happened this morning, but I'm happy to finally be connected with all of you. Today I'm going to speak specifically about the role of physical therapists in fall risk reduction, and I think a lot of people probably have a good idea of what we can do for individual patients, but I want to kind of give you some food for thought about how we might impact your fall risk reduction program a little bit more broadly. And so as Stacy mentioned, there's our funding sources on the screen, so you can go ahead and go next slide. You can advance the slide, Stacy.
1 minute, we might be having another glitch. Okay, are you still able to see the slides?
I can. I see your first slide.
Okay.
Okay, right here. I just want to acknowledge that I'm one of many people who've worked on this project over the years. You can go ahead and go next slide. And then I also want to acknowledge all the hospitals that we've worked with. These have been rural hospitals, critical access hospitals in the state of Nebraska. We really wanted to focus on these critical access hospitals to help them elevate what they're doing for fall risk reduction and determine what works specifically in that critical access hospital setting. Not a lot of the research literature about fall risk reduction focuses on those smaller hospitals. You can go next slide. And so what I hope to accomplish today is, first of all, I wanted to share with you how I feel that the skills and knowledge of physical therapists can really be integrated across components of a multi-team system. And if you were on the webinar 2 months ago in June, my colleagues Catherine Jones and Vicki Kennel presented on the multi-team system as a structure for fall risk reduction. Second, I'm going to talk about the relationship between fall type and fall injury and use that as a good example of why and how physical therapy can get involved in a more broader level. And then lastly, talk a little bit about how PTs could work with your staff about training for safe transfers and mobility. Next slide. Okay, so first of all, I'm going to start with the role of physical therapy. Next slide. And you can just go ahead and fill in all of the rows here, Stacy. This slide is just a review of some of the research literature that's out there. Certainly, we're not the first ones to study this problem, but some of the key things themes that come into play, regardless of the type of design or with the review studies, is the fact that this is a multifactorial problem. It needs an interprofessional or multidisciplinary approach, whatever term you would rather use. And so physical therapy should be one of the people who have a seat at the table. Next slide. So before we started working very specifically with our hospitals in the Capture Falls project, we did a survey of what the state of fall risk reduction was in Nebraska, and this survey was conducted in 2011, and we published in the Journal of Rural Health in 2015. And we wanted to know what are current fall rates in Nebraska hospitals and what are people doing to reduce fall risk. And so this slide just shows that in the critical access hospitals represented by the blue bar, total fall rates and injurious fall rates were significantly higher than in larger Nebraska hospitals, which is represented in the red. And the gray bars is the National Database of Nursing Quality Indicators. So it's a national benchmark as comparison. Next slide. In this survey, we had also asked we looked at fall rates not only based on hospital size, but based on what people were doing. And so one of our questions was, do you have anybody accountable in your organization for managing your fall risk reduction program? And the answers possible were no one, at least one person, or a team of people. And you can see here that you're better off if you have at least one person, if not a team, managing your fall risk reduction program. And this question, these data are presented regardless of hospital size. So it's not just the size of the hospital, but it's also what you're doing. And go ahead and next slide, please. We had also asked, if you have a team, are you regularly integrating evidence from multiple disciplines? And what you can see here is that if people were able to say yes to that, either always or frequently, the total fall rate and injurious fall rate was significantly lower. And this, again, was regardless of hospital size. Next slide. And then this particular slide just highlights whether or not PTs were regularly involved in fall risk reduction on these teams. And so you can see hospitals of both sides in Nebraska were lacking in the representation of physical therapy. And very commonly, you had people in quality management and nursing. And so fall risk reduction is kind of commonly thought of as a nursing-centric quality metric, but there's a lot of other professions that can contribute to solving this problem in your hospital. Go ahead and go next slide, please. So I'm going to do a quick review of the multi-team system because I want to talk to you about how PT fits into that multi-team system. And so I kind of have to do a definition of these different teams. The multi-team system is an idea from Team Steps, which is an agency for healthcare research and quality program. And it's really just a team of teams that interact together to achieve a common goal. Next slide. There's 3 teams in this multi-team system where I think physical therapy can really play a role. And one of those is the obvious one, that's the core team. These are the people there are a variety of professions who work within their scope of practice to provide daily direct patient care. That's the core team. Next slide. Then you have what we call in Team Steps language, the coordinating team. And so this is the group of people who work on driving policy and procedure from an organizational level. And we promote the idea that this team also needs to have various representatives on it from various professions. Also, it's great if people from this team are from different levels of hierarchy within the hospital. So you might have hospital administrators who can get hold of financial resources and break down some organizational boundaries. But then you also want the people who are on the floor on a daily basis, like CNAs, who kind of really know what's going on in the real world, so to speak. And so these coordinating teams help span status and hierarchy within the hospital, and also knowledge within different professions across the disciplines. Next slide. And then the third team where PTs can have a role is the contingency team. And this is the team that conducts the post-fall huddle. So if somebody falls, try to learn immediately from it. What just happened? How can we prevent it from happening again? Next slide. So physical therapy, again, the core team is kind of what people, I think, traditionally think of our role, but I'm going to talk specifically a lot about our role in the coordinating team and also a little bit on the contingency team, how we can contribute to that as well. Next slide. I would be remiss if I didn't mention occupational therapy in this conversation, and so obviously today I'm speaking from the viewpoint of a physical therapist, since that is my profession, but I want to acknowledge that occupational therapists know a lot about movement as well, and so to that extent, they're concerned also with the quality and safety and functionality of movement, and would be good members to have on your fall risk reduction coordinating team as well. Next slide. Here I have listed just common fall risk factors. These are pretty commonly known, and the ones that I've got in red here are ones that are within the scope of practice of PT and OT, but you can see that there's also risk factors that reside in the purview of other professions as well. Next slide. So to share a little bit about the lens through which physical therapists view a fall, we look at it, first of all, from a biomechanical standpoint. And so if you look at the stick figures there on your screen, the guy on the left is balanced. His center of mass, which is the little center dot in the middle of his trunk, that line of force falls right between his 2 feet, which is his base of support. So the base of support is whatever part of you is in contact with the supporting surface. So over on the right then is that stick person is starting to fall over, and it's because the center of mass is moving outside the base of support. And if the patient can't control that and bring the center of mass back over the base of support, a fall is going to occur. So from a biomechanical standpoint, that's why somebody falls. And a physical therapist is going to look at that and we're going to ask ourselves why. Why was that person not able to control their center of mass? And so on the bottom of this slide, we've got kind of a cycle going through sensory input and motor output. So first of all, you have to sense where you are in space. You have to use vestibular and somatosensory and visual input to know where you are and know if you're starting to fall. And then if you are starting to fall, you need to have an appropriate motor response. The right muscles need to turn on at the right time in the right speed in order to correct that loss of balance. And so when somebody falls, something has broken down between those sensory and motor systems to cause the fall, and we're trying to kind of find out why is that. So this is the frame of reference that we kind of view a fall through, or lens that we view a fall through. Next slide. And so this kind of summarizes that. So we look at it from a biomechanical standpoint. What impact does pathophysiology have? You know, different diagnoses like diabetes or a stroke or Parkinson's disease. Those diseases cause physical impairments that contribute to problems with movement, and people move in the environment. And so a risk factor, you know, a fall hazard in the environment might not really pose a hazard for somebody who has healthy, intact systems, but for somebody with impairments, it could cause a real problem. So we're also considering the impact of the environment. And then the last point, the orange box there, psychometric properties of measurement, that is something that physical therapists are graduating with knowledge about. And so knowing information about predictive validity of screening tools is something that we are trained in. And so when it comes time to have your coordinating team choose what screening tool they might use, physical therapists can help contribute to that conversation by knowing something about those statistics. Next slide. So now I'm going to drill down to our role on individual teams. And so the core team, again, this is the team that we probably know, people know the most about in terms of what we do. And so if we get consulted on an individual patient, we're going to do an assessment of them and look to see what kind of impairments they have or problems with their mobility. We might prescribe exercise to them to help try to remedy those impairments, and that's detailed on the following slide. But we also might educate the patient in more efficient ways to move or safer ways to move, suggest assistive devices to help compensate for some impairments. And we're educating not only the patient, but a lot of times the family members, particularly if they're going to be helping the patient after discharge. Next slide. This slide gives a summary of some research evidence promoting the use of exercise for fall risk reduction. And exercise is probably the closest thing to a magic bullet that we have in terms of reducing fall risk. There's really good evidence that it works. The problem with exercise is that it doesn't work overnight. And so the third box you see there, that systematic review stated that you needed 50 hours of exercise achieved over 3 to 12 months as the minimum dosage to reduce fall risk. And so that's a lot of exercise. And so people don't always like to do that, and it's difficult to achieve, particularly in an acute care setting. It's just not feasible. And so that's why that last box on the right-hand side there says that there's inconclusive results in hospitals. But what physical therapists can do instead with exercise in a hospital setting is kind of set the stage for starting something and then making appropriate recommendations for discharge. Next slide. So making those recommendations for discharge placement is an important role that PTs have when doing direct patient care, to make sure that that patient's going to be safe and improve their functional mobility and reduce their fall risk. And there's a nice study that I have cited there, and all of my references are in the very back of the PowerPoint presentation. But this particular study showed that if PT discharge recommendations were followed, patients were 2 times more likely, if they weren't followed, patients were 2.9 times more likely to be readmitted than when those recommendations actually were carried out. And so PTs have a lot of valuable input for that. Next slide. So when should PTs be consulted for individual patients? I would suggest, anytime that, your nursing staff, when they're initially admitting a patient, if they notice impairments in movement during that initial fall risk assessment, that's a time to pull PT in on the core team. Certainly if the patient has a history of falls, for example, if they've been admitted because of a fall, or if they've fallen while they're in the hospital, or anytime nursing staff just isn't sure how to best move a patient. There's one hospital in our project that the culture of collaboration, it's a critical access hospital, so rich between nursing and PT. The nurses will just pull the PT aside and say, hey, I've got a new admit in room 305 and we're not quite sure how to best move this patient in a safe manner. Would you mind giving us some input and taking a look? And so even if that patient isn't on that therapist caseload yet, they work together so well, and it's an organizational goal. So nobody's saying, oh, that's not my job, that patient's not on my caseload. The PTs really work well with the nursing staff to help problem solve those kinds of things. Next slide. So these are just some other examples of good core team examples from our project hospitals. Some of our hospitals have an automatic referral set up in the care plan where all patients who are either flagged as a high fall risk or admitted because of a fall get an automatic PT referral. A lot of hospitals use some sort of strategies to communicate mobility status, such as using the right board to write Unassisted or to assist. One of our project hospitals went so far as to post photos of different transfer techniques for individual patients if things were a little bit more complex. So say, for instance, like a slide board transfer. Or just, creating that culture where there's direct verbal communication, either informally on the floor or during patient rounds. So the therapist sharing tips of how to move individual patients with the other healthcare staff. Next slide. So now moving on to the coordinating team. And so this is really kind of what I want to highlight. So this would be a PT having a seat at the quality improvement table, on this organization-wide team that's going to drive policies and procedures. And so again, we're looking at it through our lens of biomechanics and pathophysiology and the environment and so on. But here's where we can use that knowledge to have a broader impact. And so, for example, we can give input from our frame of reference on fall risk policies and procedures. So for example, when should a PT be ordered for different patients? How is it feasible for PTs to get involved in patient rounds or post-fall huddles? What process is in place to make sure that that happens? The photo there shows a gait belt on a bedside table. And so in a few of our project hospitals, the PTs have been strong proponents of making sure there's gait belts available in every single room so that they're more easily accessible and more likely to be used. And so the hospital developed a policy where housekeeping was involved in laundering a gait belt and making sure when the room turned over, a fresh gait belt was placed in every patient room so it was there ready to go right off the bat. Patient education is a big part of what we do as physical therapists, and so to that extent we could give some good input regarding health literacy when it comes time to create or select education materials. And I had already mentioned our knowledge about predictive validity with screening tools that we can help interpret those types of data as well when you're choosing a fall risk screening tool and trying to eliminate those false positives or false negatives. Next slide. The two photos here on the top, the H2, those are magnets that one hospital decided to use to communicate transfer status, and so that those go on the door jamb, and so that means Hoyer and 2 people in that case, or little laminated signs that hang on a hook on the wall so the PT can communicate mobility status to nursing staff. And so, again, having input on how are we going to communicate this kind of information about our patients amongst ourselves. PTs can give input on environmental modifications of your hospital. So if your hospital is going through a remodel, to help design the bathrooms appropriately or the shower areas. This is an example of a chair that PTs and OTs would love and likely recommend because the arms slip out of the way. Makes it a lot easier for patients if they're not able to come up to a full stand and you just have to do a squat pivot transfer with them or a slide board transfer with them. A chair like this is going to be a lot more useful for that than, say, a rocker recliner. And so, PTs are the ones who are probably going to think about that more so than anybody else on your team. And then when it comes time to collecting fall event report data and looking at it for trends and trying to learn from that data, again, we just have a different frame of reference that we're going to be looking at that data from compared to the pharmacist, compared to the quality improvement manager, and compared to nursing. Next slide. So the role that I want to highlight on this one has to do with providing annual education and competency assessment for other staff. And so that is, again, a really great area that PTs and OTs can have an impact if we can work on checking off people on how to safely assist patients with mobility. And that could be something that can be done during annual competency education or new employee education. So more to come on this with my later objectives, but I'll mention it here to start. Next slide. Okay, this slide just mentions, kind of illustrates the fact that PTs can also be involved in those post-fall huddles. And again, because we're going to be looking at the fall based on, how did the biomechanics and the sensory and motor input of that patient, how did that kind of interact to create that fall? So we're looking at it based on the mobility status, whereas other people in the huddle are going to be looking at those other factors. The difficulty with PT participation in post-fall huddles is that we're not always around when the patient falls. So if a patient falls on the night shift, the PT is not going to be there to participate in that immediate huddle. And so some of our hospitals that have worked in our project have developed some workarounds for that, whereas, obviously the PT is not there for the immediate conversation, but they get notified when they come in the next day that a fall has occurred. And so they'll look at the fall event report and have kind of a delayed conversation with the charge nurse, with the nurses who are caring for the patient that day, with the pharmacist, with the coordinating team, to give their input to see if there's anything additional that they could identify to help that patient from preventing falling again, or to identify more of a systematic problem that needs to be addressed more broadly across the facility. Next slide. So the next couple slides just offer some quotes from PTs who've been involved on these coordinating teams in our project hospitals. And they really speak to this idea of spanning boundaries between members of different professions. And these quotes are mostly specific to nursing and PT. But this one says, one of the things that we've tried really hard to do is improve communication with nursing staff so they understand we have the skill set to help solve some of those problems when they have patients difficult to transfer. They rely on us a little more now to give them advice how to manage a patient better or what is safe. And so when a PT and a nurse are working side by side in the coordinating team, what happens is that they start gaining, better respect for each other. They're, better knowledge about what each other knows and can contribute. And then they go back to their identity groups at the bedside, at the core team level, and talk about, like, wow, those nurses, they really know their stuff. And, this goes for the pharmacists and other professions as well. But it has this kind of trickle down effect where everybody just has a little bit better appreciation for each other's knowledge and skill set. Next slide. So I'm going to highlight the quote on the bottom. Now that we're part of the coordinating team, we're working with nurse supervisors and directors from across the hospital. They can help communicate to their nurses the benefit of conversing with therapy on individual patients every day. And so it really has a good impact. Again, it's this trickle down effect even to the core team level. Next slide. So now getting into objective 2, this is where I'm going to share some data from our work and also some research data from others that talks about the relationship between if a fall is assisted or not and whether or not a patient gets injured. Next slide. And go ahead and fill out those 3 photos, Stacy. Okay, you can stop there. So really the first study to kind of look at this issue of relating assistance during a fall and injury was Krauss in 2007. And they have data from close to 4,000 falls from 8 Midwestern hospitals. These were in the St. Louis area, so they're not exactly small hospitals, but they were Midwestern hospitals at least. And they looked at what factors were most predictive of injury for a fall. And the results are presented as odds ratios, which is an estimate of risk of an event. Anytime an odds ratio is greater than 1, that means an increased risk of the event, and the further away from 1 it is, the more magnitude of risk there is. So for example of how to interpret these, being in the bathroom. If a fall occurs in the bathroom, the odds of an injury is 1.46 times more likely than if the fall occurred somewhere other than the bathroom, okay? I'm going to highlight the one on the right. And so if a fall is not assisted, okay, so if you're not doing what's shown in that picture and lowering the patient down to a ground, the odds of injury is 1.83 times greater than if the fall is assisted, okay? And then there's a quote at the bottom, Stacy, if you want to click one more time. So this is a quote from the discussion section of this paper. Even if fall rates remain the same, increasing the proportion of falls that are assisted by a staff member could help decrease injury rates. So this is kind of what I want us to do is plant a seed for you that assisted falls, even though they do go into your total fall rate, should be viewed as more of a success than a bad thing. It's the unassisted falls that we want to avoid. Next slide. Staggs is another research group that considered this problem, and they looked at many factors that increase the odds of injury. But again, the one that I want to highlight here was the unassisted fall. So in their data, which was based on over 150,000 falls reported to the NDNQI, an unassisted fall resulted in odds of injury 1.6 times greater than assisted falls. So again, increased risk for injury. Next slide. Staggs went on to not only predict injury, but they wanted to look at what factors were predictive of a fall being unassisted. And so what I have listed here in this table are what factors were statistically significant to increase the likelihood of a fall being unassisted. Male, gender, interestingly, maybe less likely to ask for help. Probably the one that we can do something about is not having a fall prevention protocol in place, and so making sure that you have that policy and procedure and implement it for the right patients is going to reduce the risk of a fall being unassisted, according to the Staggs data. Next slide. Okay, and then go ahead and just fill in the slide, Stacy. So these are some quotes out of the Staggs article that really, again, get at this idea that not all falls are created equal, that we should look at assisted falls in a more positive light and really focus on reducing unassisted falls. So when a fall occurs with assistance, it basically means we were in the right place at the right time, we knew that patient was going to need help, and we were positioned appropriately to do so. And they suggest that a more appropriate safety goal than looking at total falls is looking at specifically trying to reduce those unassisted falls, since those pose that greater risk of injury. And assisted falls should not be viewed necessarily as a failure for the hospital staff. Next slide. And this is a couple quotes from a follow-up article by Staggs. Unassisted falls uniquely reflect quality of care. It basically means that we weren't there, we didn't know the patient needed help, or we were just unable to help for some other reason. And attempts to prevent all falls could discourage appropriate patient mobilization. And so when total falls are the metric of your success, staff may consciously or subconsciously reduce patients' exposures to situations when they may fall. So you might choose to maybe just do the bedside commode rather than ambulate to the bathroom because it's less risky to go a shorter distance. And so, preventing all falls at all costs could have that potential unintended consequence of limiting the mobility of your patients. Next slide. So now here are some of our data. So our initial cohort of Capture Falls hospitals included 17 hospitals. They reported 353 fall events to us. And this looks at just a simple relationship between fall assistance and injury rate. And so the frequency of injury for unassisted falls was close to 36%, whereas it was only 20% in assisted falls, and that was a significantly different frequency between those two fall types. Next slide. Now, this particular slide, we went ahead and did that. We looked at those odds ratios similar to those other papers. And so in our data, we found that age was predictive of injury as well as being in the bathroom, and then notably not doing what's shown in that picture, so not assisting a patient with the gait belt. They were 3.65 times more likely to be injured. I'm sorry, 3.65 times, the odds of injury was 3.65 times greater if they were not receiving hands-on assistance with a gait belt at the time of the fall versus having that hands-on assistance with a gait belt. Next slide. These were our predictive factors for a fall being occurred in an unassisted fashion. People who were older and cognitively impaired were more likely to experience an unassisted fall than an assisted fall. People in the bathroom were more likely to fall unassisted, probably because there's that tension between privacy and staying in the bathroom with a patient. Most dramatically is the picture in the bottom right-hand corner. The odds of a fall being unassisted were almost 7 times greater if the plan of care did not indicate a gait belt should be used. So this basically suggests that if we're failing to identify someone as needing that hands-on assist, and if it's not part of our culture to think of gait belts as an intervention, they're 7 times more likely to fall unassisted than patients who actually are on our radar for needing this kind of assistance. I mentioned before, anything greater than 1 in an odds ratio means it's significant. An odds ratio of 7 is huge. That's huge in terms of odds ratios. Next slide. So the recommendation would be, make it easy to use gait belts. And so first of all, just make sure they're available. So some hospitals have started just hanging them on a hook inside the door of every bathroom, or creating a safety cabinet outside the room that has all sorts of equipment related to fall risk reduction, like slipper socks and gait belts. And I already mentioned this example about housekeeping, laundering, and placing clean gait belts in the rooms. Next slide. The other thing that you can do to make it easy for people to, staff to assist patients appropriately is to have your therapy staff engage in training, annual competency training, for how to safely assist patients with transfers and mobility. Next slide. So there was a really great editorial that was just published in June in the Journal of the American Medical Association Internal Medicine that relates perfectly to this topic. And the title of it was "The Tension Between Promoting Mobility and Preventing Falls in the Hospital." And so the authors kind of highlighted that fall risk reduction programs can have that unintended consequence of limiting patients' mobility, because people assume if we keep patients from moving, they're not going to fall. Well, that might be true in the short term, but it's not going to be good for those individual patients in the long run. And so limiting mobility is going to lead to a reduction in strength, a reduction in independence with mobility, which will result in increased fall risk after they discharge from your facility, even if you're able to keep them safe on your watch. And so this kind of, again, goes back to the idea that, you know, we shouldn't necessarily be scared of allowing an assisted fall to occur, because it meant we were in the right place at the right time and we knew how to assist that patient. So those should be viewed more as a success. So we shouldn't avoid mobility at all costs. And I like one point that these authors made in this particular article. They suggested that maybe we need to start looking at fall prevention teams in a more positive light. So yes, we want to prevent this negative outcome, but maybe if we look at them in terms of patient mobility teams, you know, how do we keep people moving but safely, that we can just look at it from a more positive connotation. Next slide. This particular slide shares some data that was based on a research study. It was a survey done with nurses and PTs and OTs about barriers that they perceive when it comes to mobilizing patients. And the two I really want to highlight are the ones in the upper right-hand corner, the feeling that I have inadequate training on how to safely mobilize patients and that I have less confidence in my ability to do so. And so those two things, not surprisingly, are correlated with each other. And nurses tended to report greater perceived barriers than therapy staff. And that's not really surprising to me either, because, you know, nurses have a lot on their plates besides helping people with movement. And that's what therapists are trained to do. But, you know, I kind of take this to suggest that this is an area where the therapy staff can really help the nurses be better trained and have improved confidence. One of the other findings in this particular paper was that more work experience was associated with lower perceived barriers. And so, you know, the more practice and the more experience that people have with moving patients, that's going to reduce the barriers and not lead to that conflict between fall risk reduction and mobility restriction. Next slide. So having your PTs and OTs provide training to hospital staff on, you know, share what we know about how to move patients in a safe manner to improve the likelihood that falls are going to be assisted falls than unassisted. And so this could occur annually during annual competency training when you're doing your bloodborne pathogen and your fire drills and all of those things. You know, have this topic in there as well. The therapy staff can work with the nursing and CNA staff, I would say, at a minimum, since those are the ones that are going to be hands-on, working at the bedside with the patients most frequently. But you might also consider other staff as well. I was just having a conversation yesterday with one of the radiation therapists that I work with in my college, and she's interested in improving their curriculum on how those students learn how to safely transfer patients on and off the radiation therapy table. And so she was looking for some resources for me for that. And so those type of staff have to move patients as well. And even ancillary
Hello, are you guys still there?
Are you there?
I am still here. I don't know what happened. I had static on my line, and then
All of a sudden, it hung up on me, like dial tone.
oh,
All right, we can hear you loud and clear.
Okay, good. Just plagued with all sorts of problems today. Okay, so I think I was talking about, who you might want to do training with. And then lastly is the how. And so ideally, if you have the luxury of time, it's good to actually have people not only get demonstrations on how to do these transfer techniques or use a gait belt, but have the staff demonstrate it back to you. That does take quite a bit of time. But it is best for learning and truly seeing if somebody is competent at the skill. Next slide. Okay, so part of our charge from the Agency for Healthcare Research and Quality grant was to create a toolkit for fall risk reduction. And one of the tools that are available is, we call it a Safe Transfers and Mobility Training Gap Analysis. And the full document is available at that website there, and I've just cut and pasted a few sections of this document to highlight. And this is basically, therapists at your facility could use it as a checklist of topics that they might want to include in some annual competency or new employee orientation type of training about this topic. So for example, just some basics about postural control, like the biomechanics examples that I gave you earlier. How do you put a gait belt on? Next slide. The form goes on to give you some very specific information about different types of transfer techniques, such as how do you optimally position a patient in order to complete a sit-to-stand transfer, what sort of aspects of wheelchair management should be taken care of prior to a transfer. Next slide. And you might choose to have some diagnosis-specific type of information that your therapist review with your staff. For example, if your hospital does a lot of joint replacements, you might want to talk about specific gait and transfer techniques that are specific to those diagnoses. Next slide. And then there's a question on there that talks about, like, what kind of format do you offer your training? And so it's certainly, it's very easy to do online modules or videos as far as time efficiency goes. But if you can do that actual allow for practice and have people demonstrate the skill back to the therapist so that they can receive some feedback, that's really ideal. Next slide. And the reason that it's ideal is because people are going to retain more that way. And so this is a pretty classic pyramid based on educational theory about how much do people retain with different teaching methods. And so you notice lecture there is at the top. And so you will remember probably very little of what I said today, since this is essentially a lecture. And as you move down the period, it's more active engagement. So people learn better that way. Next slide. Again, I mentioned the fact that we have created this toolkit. This information is freely available to anyone. This was a federal grant, so any of the hospitals on the phone call today or who listen to this webinar at a later point in time can go to that website and get all sorts of different tools. There's various learning modules on different topics, fall-related topics. Of specific note relative to my topic today are 16 mobility and transfer training videos. These are some training videos that I had a hand in creating that are meant to be kind of a video library that PTs and OTs at hospitals might use to supplement the training that they provide on safe transfers and mobility. And so they're standalone, they're all narrated. So this might be a situation where, staff is supposed to kind of view these on their own and then come ready to practice the techniques that are shown in the videos. And when I created these, I purposefully did them fairly general. They're not anything diagnosis specific, but just general tips and practices that you can do to safely move people in and out of bed. How do you assist a fall if it happens when somebody is walking, those sorts of things. Next slide. So this is my summary slide. So we finally made it here despite the technical difficulties. And so what I hoped to convey to you all today is that, you know, PTs have this knowledge base that really complements. It's unique compared to other people on the team, and so it should complement the other team members, and that we can use this knowledge base as members of the core team, the coordinating team, and the contingency team. I've shared some information to show how assisted falls should be viewed as a success because they're less likely to result in injury, and focusing on reducing unassisted falls in your facility versus all falls might actually better promote mobilization of patients. And then let the PTs, get the PTs and OTs on your staff involved in making sure that your staff has confidence and lowers those perceived barriers for them in terms of how to safely mobilize the patients. That will increase the chance of your falls being assisted versus unassisted. Next slide. Okay, so at this point in time, I would just again like to thank you for the invitation to present, and if there's a few minutes for any questions, I'd be happy to entertain those.
Okay, and I will go ahead and unmute the lines for just a moment. If you do have questions, feel free to speak up on the line, or you can type them in the chat box as well. And Dawn, if we have people that have questions maybe after the fact, if they send those to me, would I be able to forward those on to you?
So that would be, you know, I have my contact, my email information there listed directly on the slide. They could email me direct unless you want to keep track of the questions in yourself.
Okay. That would be all right. If anybody has questions, you can send them directly on to Dawn. And here are the resources that Dawn mentioned earlier. Okay, and with that, that concludes our summer capture series. It's been a great opportunity to work with the University of Nebraska Medical Center as they've shared their knowledge, and I really want to send a special thank you to our presenters, Dr. Catherine Jones, Dr. Victoria Kennel, Dr. Dawn Venma, and Ann Skinner. It has been a wonderful experience getting to learn from all of your knowledge. And as a reminder, Lana Comstock is the lead for the Falls Community of Practice. If you have questions or concerns, her email address is on the slide. And this is our South Dakota partners for the Compass HIN work. And as always, the Iowa Healthcare Collaborative Compass HIN team. Just know that we're here to assist you to meet any of your quality goals. We can provide resources, training, consultation. So if you have questions, feel free to reach out at any time and we would be happy to help. And with that, I think that will conclude our community of practice for today. I hope everybody has a great rest of your day. Thanks for joining us.